half the time, people who are traumatized as kids who hear voices, the actual content of the voices is directly linked to the trauma. So it's very often the voice of the perpetrator telling them to do horrible things or telling them that they are a horrible person and they should kill themselves. There's only 3 or 4 studies ever been done on that. Nobody ever talks about it. About 15 to 20% had some sort of biological explanation. 70% had psychosocial explanation. So some had both, overlapping, but the vast majority had a psychosocial explanation. Here's a couple, though, I think are illustrative. I believe being raised in a house with a dad with anger issues led me to live in a constant fear as a child. But I didn't understand that fear. So instead, it changed to paranoid thinking like monsters or demons were coming to kill me. Then I developed protective delusions, such as me being a werewolf or God. It's still crazy because he's not a werewolf, but it makes sense in the context of his life.
Today, it's great to have Dr. John Reed here with us. He is, it's Professor, right?
He's that.
Yeah, we'll go with that. John, yes. Okay, yeah. So he's a professor at East University College, London. Is that the
University of East London?
University of East London. Yeah, great. And John talks about a lot of things which he told me before we really got started aren't actually that unpopular, but in academic psychiatry, at least in the US, they seem very unpopular. Issues about the evidence basis on the treatment of schizophrenia, psychotic illness, where antipsychotics, how they should be viewed there, where psychosis comes from. He's been talking about this stuff for decades, and he's also been looking at the research behind ECT, and we're going to go into all of that today. But, John, before we get into it, I think it would be best to just kind of tell us a little bit about your background, because I was, before we kind of really got into this, I was just saying, how does someone, survive in academia and kind of make it this far, with these supposedly unpopular opinions? Where did you come from, and how did you get here?
Great question. Where did I come from? Better ask my mum and dad that.
Yeah.
I think the important thing to say is that, like many teenagers, I was a complete mess. And on a good day, I spent my time trying to figure out what was wrong with the rest of the world and why were they so crazy. And on a bad day, I was trying to figure out why I was so useless and crazy. And so obviously I came to university trying, the obvious subject to take was psychology. So to try and figure out what was wrong with me or everybody else or my family. But unfortunately, undergraduate psychology teaches you nothing about any of that. Teaches you about what part of the brain lights up when you go to the toilet or have a certain thought. Yeah. So anyway, most of my learning was done by, to be honest, the very first job I got was as a nursing attendant in New York, in a psychiatric hospital in New York. And the patients there taught me most of what I know. And then after that, I did, the formal training in clinical psychology. But it was basically, I think like many people in mental health, the real reason, if we're honest, that we're there is that we were a bit of a mess ourselves and trying to, so that which makes it, the whole thing interesting, in the first place. And I particularly just got interested in psychosis, which is it's always been my main area of work as a clinician. And then later as a researcher. I can't really explain that, except that I think looking back on that work in the hospital, if I'm honest, I think I liked it there a lot because it made me feel better that there were people even crazier than I was.
Okay.
And because I was a bit of a mess, I didn't find it very difficult to relate to them. Like the stuff they were talking, which seemed to freak out some of the psychiatrists, seemed to make perfect sense to me. Interesting. So that's my attempt to answer your where did you come from question.
Sure. Yeah. And let's drill down there, and we'll kind of talk about psychosis a little bit. And what's your perspective? I'm going to take the 36,000 foot question here. What's your perspective on the way that we treat people with psychotic illness these days?
Well, my perspective is pretty much the same as my perspective on how we treat anybody with any so-called mental health problem or mental illness, is that we are completely over-medicalized and reductionist and simplifying things. So as soon as we take a medical approach, I don't see these things as medical events. That's the bottom line. We're using the wrong paradigm to treat what are social and psychological issues. So my take is that as soon as we apply a medical sounding word like schizophrenia, for instance, which has very little scientific reliability or validity, as soon as we apply it, we think we've explained the problems that the person's having, like hearing voices telling them to hurt people or hurt themselves, or believing that the world is out to get them. We think we've explained it because we go, now I know why that person's hearing voices, because they have this thing called schizophrenia. The problem is this is circular logic, because how do you know they've got schizophrenia? Well, you know they've got schizophrenia because they're hearing voices. So it's this sort of 5-year-old backwards circular logic, which explains nothing at all. It's just a word. But there are many people, not just psychiatrists, but many people within the mental health system that genuinely believe that using these medical sounding words means we have explained something. Whereas what we've actually done is mask the real causes, put the person in a sort of mental illness box, a category, applied medication, which we can come on to because usually that doesn't work. And often started a lifelong career of in and out of hospitals and on and off of 7 or 8 different drugs and so forth. And as I say, the problem is not a medical one in the first place. As soon as we've gone down the medical route, our chances of actually getting a meaningful understanding of and resolution to whatever the problem is very small indeed.
So that's a good place to jump in. Can you just unpack the, how you look at the cause of, schizophrenia, psychosis, chronic psychosis? Where do you think that, how do you put that together causally? If it's not from a medical condition, just unpack all of that for us. Yeah. Well,
there's 2 parts to that: what it is and what it is. So what it isn't, it's not what biological psychiatry says it is. It's not a chemical imbalance situation. And the dopamine theory, which has been around since the 1950s, has simply never been proven. The idea is that people with schizophrenia or psychosis have overactive dopamine systems, as you know, of course. But when you do studies of people who have never been on antipsychotic drugs, there is no difference. There is no overactive dopamine system. The only groups of people, which unfortunately is most people who get this diagnosis, who have overactive dopamine systems, are people on the drugs. So, and this takes a bit of explaining, and it's a bit bizarre. It's hard to take in, but since the 1970s, we have known that what antipsychotics do is block the dopamine system, and then the brain fights back. In other words, the receptors in the brain cells start trying to produce more dopamine to try and get through the blockade. And on the other side of the synapse, the brain, very cleverly, in an attempt to compensate for this artificial and damaging blockade, produces more dopamine receptors. So you then genuinely have an overactive dopamine system with the brain trying to pump more dopamine through, and more and larger dopamine receptors. Which is why, of course, when you remove the drug, we'll come on to this later, perhaps, the whole issue of withdrawal and so on. But when you withdraw the drug, you've got a massive overflow of dopamine. Anyway, that's a long-winded way of saying there is no evidence for a dopamine basis to schizophrenia any more than there is a serotonin basis to depression. These are essentially drug company-sponsored theories swallowed wholesale by biological psychiatry. which A, don't have any basis in fact, and B, are very damaging ideas, because once you communicate that to people, you're telling them there's something irreversibly wrong with their brain, which is, apart from being wrong, factually, it's a very damaging thing to say to somebody. It's like me saying, Joseph, all your problems are because there's a certain problem with your brain. It's not really fixable, I'm afraid. We can sort of artificially try and adjust it back to where it is. We can spend the rest of your life trying to juggle those drugs to try and correct it. But it is something just wrong with your brain you've got to live with for the rest of your life. And then we wonder why people don't get better. I give them this message. So there's the factual part of it, and then there's the damaging message part. So that's what it is. Well, the other part of what it isn't is genetic. So we'll come on to what the actual causes are, or what the research says the causes are. But of course, schizophrenia and psychosis are supposed to be very heavily genetically based, more so than the other mental health problems, depression, anxiety, and so forth. They're all said to have a genetic component. And I'm afraid this isn't true either. They spent the first 60 or 70 years looking for the schizophrenic gene, and then gave up on that about 20 years ago. And have since been looking for a combination of genes which might account for variants. But they really haven't found any replicable findings. They go on and on, spending millions and millions of pounds looking for this combination of genes that supposedly causes this thing called schizophrenia. And they'll never find it, partly because schizophrenia is not a robust scientific construct, whereas it's slightly different. So the evidence for a genetic basis is very, very weak indeed, but that's across the board. That's true for depression, anxiety, and everything. So in a nutshell, the biogenetic causal theories that biological psychiatry has swallowed and promulgates are not true. So where does that leave us? What are the actual causes? Well, they are, according to the research, they're all in the psychosocial domain. There isn't one single cause of schizophrenia, psychosis, of course. It's a combination of things. So the more of the things I'm going to list now, the more of these things that you have, the greater the chance in combination that you will end up with a diagnosis of schizophrenia, or you'll experience frightening voices. And those things are things like violence, abuse, neglect, war trauma, poverty, unemployment, etc., discrimination, etc., etc. And that's what the research says is increases your chances of ending up psychotic. And slowly we have begun to get that across. Certainly in Europe, I know it's still in the States is a bit of a, to many of the United States is a bit of a sort of alien planet, because it doesn't sort of fit in with a lot of what's going on around the rest of the world. It's a very biological and very drug company, even more drug company dominated than the rest of the world. But anyway, so most of my research has been around childhood abuse and neglect and the relationship between those and psychosis. But that's not.
Just one thing I want to jump.
Please do.
Yeah. I guess to me, and I want you to push back against me on this, because I've never actually had a chance to discuss this with someone who's kind of looked at the evidence base like you. I always feel like there must be something going on with certain people that they manifest in psychosis, because you could have someone horrifically abused, neglected, and they end up becoming depressed, right? And you could have someone else who ends up becoming psychotic. And psychosis really it can be quite frightening for family members. It really is something that's difficult for them to understand. Some glazed, the cognitive problems that they see sometimes, this sort of glazing over, dissociation, the bizarre thoughts. And so I always wonder, what is happening? Why does it break into psychosis for some people, but for other people, maybe it's severe depression. Maybe for others, it just doesn't affect them in the same way. And so I'm thinking like, there must be some unknown factor in there where it's like under these set of extreme stresses and circumstances that psychotic symptoms manifest. I was wondering if you could just, like, what do you think about that? Like, just the very accounting for why that happens. Yeah.
I'm actually looking for I will answer that. I'm just looking for a paper because we did a study of, I'll say what I think, but we did a survey of over 600 people and asked them that question. People on antipsychotics, so most of them they call psychosis or schizophrenia. And we asked them why they thought they had. So I've got that for them, so I can read from that in just a second, because that's never done. People are hardly ever asked, what do you think is your cause? So we really don't know, if we're honest, the answer about why one person who experiences a series of traumatic events ends up depressed and why one ends up dissociated, one ends up psychotic. And there's a lot of overlap between those anyway. Most people who are psychotic are also depressed and probably also dissociating. So we can't put these people into different categories anyway. But it seems to me to have something to do with certain events are particularly crazy making. All traumas are traumatic by definition, but if you are being, say, abused and at the same time being told that you are not being abused, for instance, I'm just trying to use that as an example. There was a theory around in the 60s, which of course is now poo-pooed by biological psychiatry, about the double bind as one explanation for why some people go psychotic. Where as a kid, you are told two things simultaneously, which are not tenable. And if that happens over and over again, you basically lose contact with reality. Reality no longer makes any sense. I'm just trying. There's a lovely quote from somebody who wrote in Schizophrenia Bulletin about their experiences. When we started publishing about trauma being a cause of psychosis and child abuse being a cause of psychosis, she wrote this very powerful letter disagreeing with us. She said, "It's not the trauma that causes the psychosis. It's the people around you telling you that the abuse is not happening, telling you that the sky is yellow when you can see that it's blue. That's what causes psychosis as you're growing up." So that was a lovely illustration. But if I may, can I read just two or three of these? There's 650. Don't worry. Yeah. Two or three is an illustration of what happens when you ask people themselves, "What do you believe has caused your difficulties, your hearing voices?" Obviously, sometimes people will say, "I don't know, you're the doctor, you tell me." But if you can get past that reticence to say what they actually think, most of the time, not always, they will tell you about some awful things that have gone in their lives that they connect to the hearing voices, for instance.
Let's hear it. I'd love to hear it.
So, for instance, the hearing voices, I'll read a couple. The hearing voices, again, not all the time, about half the time, people who are traumatized as kids who hear voices, the actual content of the voices is directly linked to the trauma. So it's very often the voice of the perpetrator telling them to do horrible things or telling them that they're a horrible person and they should kill themselves. There's only 3 or 4 studies ever been done on that, but nobody ever talks about that. So let me just see if I can find a couple here. This was a study of 650 people, the largest survey ever done that we did online.
Maybe you could just read the title as well in case people want to look at it.
I like the title. Bad Things Happen and Can Drive You Crazy. It's the title. The causal beliefs of 701 people taking antipsychotics. Bad things happen and can drive you crazy. It's published in Psychiatry Research 4 years ago. So overall, about 15% had some sort of 15 to 20% had some sort of biological explanation. 70% had clearly psychosocial explanation. Some had both, not overlapping, but the vast majority had a psychosocial explanation for their own so-called illness. So here's a couple that I think are illustrative. I believe being raised in a house with a dad with anger issues led me to live in a constant fear as a child, but I didn't understand that fear. So instead, it changed to paranoid thinking like monsters or demons were coming to kill me. Then I developed protective delusions, such as me being a werewolf or God. Now, it's still crazy because he's not a werewolf or a God, but it makes sense in the context of his life. I suffered abuse as a child, which I think caused abnormalities in my beliefs, self-image, perception of the world, and my emotional responses. Trauma, stress, burnout, death of a parent while still a child, abusive and neglectful parenting, social isolation, and bullying. That's all one person. Extreme ongoing child sexual assault and being the victim of a paedophile network. Prolonged trauma for 9 months when I was 12. This trauma included physical, emotional abuse and neglect. It goes on and on. Incest over many years. But it's not all child abuse. There's 5 or 6 pages. I want stuff about work, difficult childbirths, poverty, isolation. And it sounds glib and it sounds simplistic, but I place more value on what these patients say about what's going on in their lives and what's caused their difficulties than the theories, the unproven theories of biological psychiatrists about what's wrong with these people and what's caused it. So we've got a very sad situation. And I'm not saying everybody with schizophrenia was abused as a child. I'm saying there's a whole range of things: abuse, neglect, poverty, loneliness. Loss of a parent is in there, loss of a parent in the first 10 years of life. As I said, there's about 10 things in combination are likely to push you over the edge, and the more you have of them. And we haven't got a formula, Joseph, that actually can predict which person will and which person won't end up psychotic versus dissociative versus depressed. But we've got an overall, because some of those people could have ended up just with dissociative disorders or PTSD or whatever. So we don't really know a great precision. And I'm not that bothered about that because, as I say, I think the overlap between psychosis and dissociation and anxiety is so much. I don't really think it helps us to obsess about what name shall we give this. Shall we call it schizophrenia or shall we call it dissociative disorder? I know psychiatrists think it's important because it then tells them what color pill to prescribe, but it doesn't tell us anything about what's going on in the person's life. So I'm giving you a long-winded answer. I'll stop and wait for you.
No, I agree with that. And I think I don't think it's really probably that informative about how to help these people as well, because a lot of the times intervention at the psychosocial level is probably the least harmful and the most effective long term. And that's exactly the same with depression and anxiety and any other mental illness. And so I guess, I think about the similarities between, depression, which I spend a lot of time, talking to people who are depressed. And it's like, why do some people collapse into a complete depressive episode under certain stresses and others don't? And it's so complicated. You look at them, some people have more of a neurotic personality, that's just their constitution. Things tend to hit them harder than others. Maybe there's other factors going on that we are just simply not aware of that will cause people to tilt into these really heavy depressive episodes of lethargy and loss of motivation. And I wonder as well as, it's just a similar thing with schizophrenia, that there is this predisposition we don't understand, and under a certain range of conditions that breaks the brain, and they start experiencing these frightening symptoms. I don't know what you think about that, but I'd love to hear your thoughts.
Okay, well, I think this idea of a predisposition is an interesting one. What I was taught, and most textbooks of psychology or psychiatry or whatever, talk about the stress vulnerability model, don't they? And the theory is supposed to be that we inherit this predisposition to either depression or anxiety or schizophrenia or whatever. And then depending on how much of this predisposition we've inherited, that will dictate how much stress it takes to push us over the edge into that particular mental health problem.
Yeah.
Now, the problem is the inventors of that theory, Zubin and Spring in the 1970s, the vulnerability part was not necessarily inherited. They said you could acquire the vulnerability, and then biological psychiatry colonized that and turned that into a genetic predisposition. But actually, both sides of that equation can be socially based or trauma based. So it makes absolute sense. And we'll come back to your example of the two people experience the same depressing events, and one ends up very, very depressed and one ends up slightly depressed. It makes absolute sense that if you've had enough bad things happen to you as a child, it's not going to take very much as a teenager or a young adult to tip you over into complete despair. Like this, this is just endless. This shit is just endless. And I must be a terrible person. Why is it always happening to me? The only explanation must be that I'm a terrible person. And I do think in terms of depression, our thoughts, our cognitions are very, very important. Self-defeating things we tell ourselves about ourselves, and about the world and our future, are hugely determinant of who ends up really depressed or not. And I think the difference between those two people who experience the same depressing event at age 18, one goes into a month-long episode of not being able to get out of bed, and the other one is 3 weeks a bit bummed out and then bounces back. It's almost entirely predicted by how many other bad things have happened to them previously. So I don't think there's a genetic predisposition to any of these things. I think it's almost entirely based on life lived. I have to add quickly, that doesn't mean I don't think genetics are important, but we've developed this really simplistic genetic model. Biological psychiatry has invented this simplistic, unrealistic genetic model, which says we can actually determine, those tables where it says it's 65% genetic and 35% environment, and all this research trying to determine what proportion is environment, what proportion is genetic. It's just not possible to determine that. You can't separate those things out. The idea that there's a genetic predisposition to any page of the diagnostic manual is just a complete fallacy. However, epigenetics. Let me just finish this bit because I have to be careful, because obviously I get dismissed as a bit extreme as saying the genetics aren't important. What's developed in the last 20 years, and you'll know this obviously, is the field of epigenetics, which instead of assuming that genes we just inherit them and they predetermine who we are, epigenetics has shown that our genes are turned on and off by the social environment. So yes, of course we inherit different things from our parents, but our social environment in the first 5 years of life has a huge impact on which of those genes actually go on to influence us or not. Plus, then I'll let you in. Sorry, I get on a bit of a roll, as you've noticed. Plus, what are we going to do anyway if we found the genetic basis? But we'll come back to that if you like. Sorry. Yeah.
No, it's great to hear your response. And I sense that there's so much caution about, falling back into this place where we're going to say, it's genetics, probably because, and you'd correct me if I'm wrong, is that you've seen probably over your career how much they use how much professionals like psychiatrists and such will kind of use genetic explanations maybe to simplify things and to create, I guess, a disempowering explanation for what's happening that maybe draws people away from other factors that are frequently seen as being causally related and are actually addressable. And so that's what I'm kind of sensing there. And And so we want to be really careful about overblowing the importance of genes whenever we're talking about this, and always remembering that, you know, genes aren't these things that we just kind of just inherit, but they interact a lot with our environment as well. And so even at the genetic level, there's that influence of our environment there, controlling what gets turned on and off.
Yeah, I think some of the genetic explanations that psychiatrists give to parents, for instance, are very well intentioned. I think sometimes it's an attempt to say, look, it's not your fault. It's not that you were a bad parent or that you should have done anything different. It's unfortunately, your family has these genes, and they think that that's somehow less upsetting. And perhaps it is for some families. Personally, if one of my kids became psychotic or extremely distressed, and I asked someone, as we all do as parents, inevitably do, what did I do wrong? If I was told, oh, what you did could have made no difference one way or the other, I'd be quite insulted. I would actually want an honest discussion about, well, something's gone wrong here, whether it was inside the family or outside the family. We need to understand it. Don't tell me that it's got nothing to do with this person's life or 20 years I've spoken with them, bringing them up. Let's figure out what's going on so that we can do something useful to help them. Maybe I need to do something different. Maybe I could be a more helpful parent. And the other part of that equation is that if a parent has been less than optimal in raising their kid, you can almost guarantee that they themselves would have had a difficult childhood. So that's this idea that, see, we got a lot of, when we started researching abuse and psychosis, we got a lot of backlash from psychiatry saying this is family blaming. You mustn't talk about this, John. This is going to upset people. This is family blaming. Yeah,
I remember learning about the schizophrenogenic mother. I'm sure.
Right, yes.
Yeah.
Yes. Yeah. That dreadful, I can't remember the name of the person who wrote that. What they wrote about is, they did some very good, Lyman Wynn back in the 70s, did some very good research, which has almost become taboo, to look at what actually is going on in the families of people who end up psychotic. They found an awful lot of pain and discomfort and dysfunctional relationships between the parents, and lots of people needing help. That's what they were trying to identify. Like, the whole family needs some help. This family is not working. And one of them is ending up in really bad shape. And then, because the family isn't getting any help to figure out what's going on, all the focus is on that one person. It's the identified patient. And the thinking becomes, if only little Johnny wasn't, complete the sentence how you like, ADHD or schizophrenia, then our family would be fine. If we can just get little Johnny medicated properly, then. But actually, behind that scene, there's a lot of pain going on, and that's all masked over by this idea we mustn't talk about what's going on in families, because that was a terrible thing to do, because the families will feel.
It's like that idea that you can't do it compassionately, right? That if you were to start speaking about, okay, so maybe this family system is working for mum, dad, and Johnny's older brother. Why isn't it working for Johnny? You know, that you know, what is it about him, his constitution, the way he sees the world, where this isn't working? And I guess instead of being able to have that conversation, that it's just blaming them, and it's like, you shouldn't do that ever. Yeah.
Yeah. And so instead they're told there's something wrong with their genes, which I don't know. Maybe it's something about me. I would find that really quite upsetting, to be told that my genes were so messed up that I wouldn't feel it was my fault, but I would feel, oh dear, that's awful. My offspring. I don't know. I'd find that. But the point is, those conversations are very difficult. I thought I won't be sitting here saying that's what we should be doing, but you need really skilled people to be able to do that, to sit in a room with a family, or to even have the skills to get a family to come into a room when there's lots of conflict. But to know what to do, family therapists have almost disappeared off the map. Proper family therapists. I don't mean the person sits down and does psychoeducation, which sits with groups of families and explains that it's a mental illness. That's not psychoeducation, that's biopropaganda, as I call it. Where in proper family therapy, where people are, there's a little bit of an open dialogue, for instance, which I'm sure you're aware of. That attempts to bring people together as a group and talk about what they think is going on. The best examples in my life, I spent 20 years in New Zealand. And Maori people cannot understand why us white folk would, as soon as somebody became psychotic, we would get them away from the family, and we'd talk to them in individual one-on-one private rooms, where no one was allowed to know what was going on in there, which to us is confidentiality and makes perfect sense. To them, this was crazy, because the obvious thing you need to do is get together everybody that's ever known this person. Sometimes they have groups of 20 people or 30 people. They had a word, whānau, which means extended family. And everybody got together to try and understand what is going on in our whānau, that our little so-and-so has ended up in this mess, and what do we need to do? They couldn't understand this white idea of it's just something to do with the individual. They couldn't get it at all.
Because maybe they don't understand the business of medicine, because
that's right.
I think when you I'm thinking about it because pulling someone out on an individual basis, bringing them into a room like it's a production line, man, that's a whole lot faster than taking the time to understand how does mum see the world? How does dad see the world? What are the values in this family? How do they expect little Johnny, who's having psychosis, to be acting? Why do they expect him to be acting that way? How does Johnny see things? Like, this is a lot of work. It's incredibly time consuming.
It is,
it's not something that's scalable. And so I think that's the reason why I think so much of this treatment happens in isolation. We'll pull the kid in, talk to him for 40 minutes, and then, give him a treatment. And that's the business of medicine right there.
Yeah, but it's a simplistic answer, Joseph. But if you took half of the profits of the drug companies over the last 12 months, I could build your mental health system that had so many resources and so many skilled family therapists. We'd have too many. With the money's there, it's going in a strange place. It's going into the pockets of shareholders of drug companies. That's where the money in mental health is going. That's why there aren't the resources to do what we actually need to do. That sounds like a conspiracy theory. It makes me sound paranoid. That's fine. I know a lot about the drug companies and how much they've influenced the world that I just wanted to be an ordinary clinical psychologist. That's all I ever wanted to do. I just wanted to work with people. For some reason, I was quite good at doing therapy with people who were really crazy. That's what I loved doing. It was undermined so many times by them being over-medicated and being told these damaging things. I ended up in the role I have now, which is more of a combatant, it feels like at times, trying to fix the system. So I don't know what started me off on that rant, but it's like,
well, let's kind of pick up there, because
it makes me cross when we talk about not having the resources. And as you quite rightly said, we don't have the resources, but the money's there. We're just spending it in the wrong way.
Yeah. So I know you're not working clinically now because you shared that, and I can't not pick up on what you said. What happened to have you step away from the clinical role? What was it about your work that kind of pushed you in this direction?
The anger that I felt on a day-to-day basis, like for instance, I worked in several inpatient units in New Zealand, in America, in England. The anger that I felt on a day-to-day basis, seeing people's lives made worse by what they were being told, by the medication, by the very act in inpatient units. I mean, the idea that it's a good idea to gather together the 40 most disturbed and disturbing people in a community and put them in the same building, that by itself is insanity. So I couldn't live with my own crossness at it, and the futility of the efforts of myself, and a lot of the nurses were really good people trying their best to connect, but it was all overweighed by this message that there's something wrong with you. And anyway, the people were usually so heavily tranquilized they couldn't benefit from the sort of relationships we were trying to build with them. It just seemed futile at best and damaging at worst. And I thought, I'm going to spend the next 40 years of my life working in a system like this, trying to sort of pick out the one or two people I can maybe rescue from this mess. And I thought, no, I which is what I wanted. As I say, I wanted to do that work. I loved it, difficult as it was, but I did love it. I thought, no, I have to find a different role. This has to stop. I have to find kindred spirits to work with to try and change the system, because I can reach 2 or 3 people a year maybe, but there's millions getting just really quite damaged by the mental health system around the world. So grandiosely enough, I chose a different route, and the academic route for me gave me an opportunity to research the real causes of psychosis, but also to use that ground as a sort of ground to stand on to publicize the problems with our mental health system and to call for improvements, which, as we said at the beginning, are sort of seen as a bit unpopular until and maybe this is the right time to just bring this in quickly, until we look at the surveys where around the world about when you ask people what causes psychosis or any other mental health problem, and the public knows, right, because they repeatedly say so in these surveys, that mental health problems, including schizophrenia, are caused by bad things happening. They have the same views as these 650 people in this paper. They include biogenetic stuff, but it's way down the bottom of the list. And just last year, November of last year, the World Health Organization, the United Nations, came out with yet another document, a combined document this time. They've been putting out separate documents for years. They got together to put out a document calling for a complete paradigm shift away from what they call the damaging medical model and its emphasis on diagnosis and drugs and its ignoring of psychosocial causes and therefore psychosocial solutions. So these ideas are not unpopular or unusual. They're only unpopular with not all psychiatrists, even, but a lot of psychiatrists and drug companies. Those are the only people that are actually pushing this idea that when we're upset, there's something wrong with our brains or our genes.
Yeah. I mean, it's hard to, I think, get a lot of psychiatrists maybe to buy into the fact that maybe they're not really helping people because, they've trained up to help people in a certain way, and to hear that, oh, actually, all of these years that you've been doing here, you've actually been making the problem worse.
It'd be like somebody coming to me and say, John, all that therapy you did for 20 years back then, not only did it not help people, it actually caused brain damage and shortened their lifespan. I'm not going to hear that. Cognitive dissonance is a wonderful, powerful defense. We all, Paul Simon said it better than trying to explain cognitive dissonance. Man hears what he wants to hear and disregards the rest. That's what cognitive dissonance is. And we all use it. I mean, how can you explain to an ECT doctor that what they're doing is undoubtedly causing brain damage and memory loss? They believe they're saving lives. They genuinely believe they're saving lives.
Yeah. I'm going to touch on ECT soon, but I want to wrap this up first because we ended on kind of a bleak note, and honestly, it may not get any rosier than this, but let's talk about the treatment, the prognosis of people who are diagnosed with schizophrenia. I get people reaching out to me all the time. These are mothers with teenage sons, early 20s. Maybe they use some cannabis, have had a psychotic episode. They're on, Risperdal, Zyprexa, something like that. They've been doing it for 3 or 4 years. They found anatomy of an epidemic. They're frightened. They don't know, oh my God, I never looked into this earlier on. Maybe my son's still having some kind of problems. I know you're not working clinically, John, so I know this is not going to be clinical advice from you to them. But if you were to just speak kind of like, how should these family members start thinking about caring for their loved ones when they're starting to have a more critical view of the medication, and maybe they actually want to see how their son is going to go off the meds. How do you help someone navigate that situation, just knowing that there's not a lot of professional resources?
Okay, well, let me start by, I was struck by you saying I don't know what words you used, but we were painting a fairly pessimistic picture. Let me just respond to that first. So this thing called schizophrenia or psychosis, if it's left alone, if it's not treated, has a hugely wide range of outcomes. Some people will have one psychotic episode in their life and that's it. Others might have one once a year or something, and other people will have them more often, and there's also a range of severities. So I guess in a long-winded way, I'm trying to say that a lot of people who have what a psychiatrist would label schizophrenia would just come out of it. The same way people who are depressed, we're so quick to get antidepressants, and if you watch and wait, most people will come out of depression. Not all, but most will come out of the depression by themselves. Time is a great healer. So psychosis, first of all, is not a lifelong sentence. And so that's important to remember. If we ever got to the place where we could just do what Lauren Mosher and Sateria House used to do, just provide a supportive environment to help somebody through the experience they're having, many people will just come out the other end and be fine. What we do, however, is lock them in to the psychosis with the labeling, the biogenetic message, and I'm afraid the drugs. So that's where the pessimism comes from the approach we take. So to answer your question, what can mums and dads do in that situation, or the people themselves? Well, the first thing they have to do is inform themselves, because very often they're not informed by the psychiatrist. The psychiatrist, perhaps well-intentioned, either doesn't know, which is unlikely, or more likely, chooses not to tell people what the side effects are. And the reason they do that, I believe, is because they fear that if the person knows all the side effects, they won't take the medication. So you have to inform yourself first. So you're making an informed decision about whether to stay on or whether to gradually come off. And I stress the gradually part, which we can come back to. Some people, right, let me choose my words carefully here. I believe I'm not anti-medication. I am against people not being given choices and informed choices. So I do think that taking a drug, which is essentially a tranquilizer, that's what antipsychotics are. They have no actual antipsychotic properties. There's nothing in them that cures or even ameliorates psychosis or schizophrenia. What they do is heavily tranquilize people. And I believe there's a role for that. I think the safer drugs like benzodiazepines you can use, but I absolutely do think sometimes people are so upset and so confused and so scared that it makes sense to calm them down for a while. So the drugs in the short term are not the problem. The problem is the long-term use of these drugs. And so people need to be informed, and it's not a pleasant process learning about it, because you learn that these drugs can cause, some of it's obvious, the massive weight gain that happens, the diabetes, the sexual dysfunction. What people don't know is the brain tends to become smaller over years, and lifespan is shortened. They're really very, very powerful drugs. So it's this painful process, where you discover Bob Whittaker's book or however you learn it. That's a painful thing to realize. Oh my God, this is what my son or whatever daughter is on. And then the decision making is the next step. Do we try and get them off? And that's a difficult process, because the fear is, oh my God, if they come off, they're going to become really crazy again. And that's where you need more information, because you need to know, this is what information is so crucial. You need to know that sometimes when you come off these drugs, as I said earlier, you do become a bit crazy because you're overwhelmed with dopamine. The dopamine was blocked, and if you take it off too quickly, if you take that block off too quickly, you are genuinely overwhelmed with dopamine, which means you're overwhelmed with feelings, overwhelmed with thoughts. So you are genuinely crazy as a result of coming off the medication too fast. So if you decide to do it, you have to do it. I almost always very slowly. I know one or two people in my lifetime who have managed to do it cold turkey. Most who try and do it cold turkey end up back in hospital with the belief that the schizophrenia has come back. So the medication gets increased. So this is all sort of information that parents and patients need. And the difficulty is, and I'm sure the mums who talk to you, Joseph, will say this all the time, when they decide to try and come off, then they can't find any support because the psychiatrist, from a well-meaning place, the psychiatrist is scared. I can't have Johnny or Jane come off the medication because she will go mad. And of course, it's this underlying fear that they will go mad, and if it's a male, they will then go on and hurt somebody or hurt themselves, if it's male or female. So the genuine fear from the psychiatrist. And the doctor will be liable. Yes, and this is where it's all very well for us psychologists to moan on about you psychiatrists and all, blah, blah, but psychiatrists carry the cat. When somebody dies, it's always the psychiatrist, not the psychologist or the nurse or someone, sometimes the nurse, but always the psychiatrist. So it's a huge pressure. And your colleagues will all think you're negligent if you let somebody come off medication. So they're under pressure. So you've got the parents. It's difficult. If someone is not under the Mental Health Act, then they have the right to come off. And again, then the problem is that if you start coming off, the psychiatrist has the power to put you back in hospital or community treatment order or whatever. So it's difficult. The good news is that if people can gradually and carefully come off the medication, there is a life waiting for that person at the other end. When we did a similar survey of people's similar number, it was the same survey, different part of the same survey that I talked about earlier, 700 people, about the process of coming off. A lot of them did talk about how scary it was, how overwhelmed they felt by the feelings. But about a quarter, even while they were withdrawing and experiencing the withdrawal effects, talked about the joy of beginning to feel something again, the joy of their life feeling alive again, although they were scared that it would to end up back in the hospital, because these drugs are very, very, very powerful tranquilizers. And people, another way to come at this is if we don't provide support for people when they want to come off, they throw the damn things away anyway. We know that 50% of people throw their drugs away within 9 months of being put on them. And they do that because of the adverse effects. So but then we all bury our heads in the sand. Well, we can't help them come off carefully and slowly and properly, because it's too awful to contemplate. So the consequences of them coming off. So they throw them away in desperation. They just stop taking them. And then they end up back in the hospital. And then you've got one view saying, well, that's because you didn't help me come off them carefully. And the view over here is, no, that's because you've got schizophrenia. And if you don't stay on the drugs, you will go crazy. So we've got this miscommunication. I'm not sure this is helping, Joseph, because it is a bit bleak, no. but there is a way through if people can be supported to come off carefully and slowly and to just keep looking for that one doctor who might be supportive. They're out there, obviously. It tends to happen quite quietly because their colleagues find out, they get a bit, they get told off. That's which is terrible, which is a shame.
Well, I think what you said is helpful, and I'm going to recap a few things because I think a recap is warranted here, and then kind of give people a lay of the land just based on what you said and have you react to it. So it seems like the first part of it is just to realize that there's uncertainty with psychotic illness, right? If you are going to remove a drug, there is a chance that a psychotic episode never turns up again, there is a chance that maybe it turns up every 3 to 5 years or some random amount of time that's not that disruptive, and you just kind of go through it. Or there's a chance that there may be some psychotic symptoms that just kind of continue, and you're going to have to wade into that uncertainty, aware of that, and just say, well, do I think my loved one is going to be better without the medication, kind of just rolling through periodic episodes of psychosis or not? And that doesn't mean no medication ever. It just may mean as needed medications when they consent to it and when they're wanting to do it. And so there's this first part of it, which is like the uncertainty of what's going to happen. And I think the other part is, there may actually be a lot to gain by being off the medications, because like you said, they're tranquilizers. People may feel more depressed on them. They may have less motivation. They may enjoy their life less. And so being in a non-drugged state, even with occasional episodes of psychosis, so long as they are safe, that may be preferable. So I think that's what people are looking at, with this journey. The other part of it, which I think isn't talked about enough, and what I was thinking about what you said, is a lot of people have to go on this journey alone because of the way our system is set up, because a psychiatrist will not do this because it will be against what's in the guidelines. If something goes wrong, there's going to be no shortage of colleagues who are going to stand up and say, Dr. Josef withdrew this patient off medication. No, most reasonable psychiatrists would not have done that. They're going to have a huge target on their back, in a legal sense, should anything go wrong. And I think recognizing that, although that's scary, is helpful, because, you will unfortunately be on your own in many cases doing this, because no one will help you who wants to carry that liability. And so I think that's why we have groups like, people doing this online, the Hearing Voices Network, who kind of try and support people, but it's very hard to find any group of doctors, MDs out there who are going to put their hands up to do this. And so I think that's just the honest truth about it.
Yes, I think that's a reasonable summary. There are things that help in the process. You mentioned one right there, the Hearing Voices Network. That's a hugely exciting development, I think, around the world, where people can go, not specifically around psychiatric drug withdrawal, but to get the support that's sometimes lacking in the mental health system. And States has many cities with Hearing Voices groups where people support one another. It's very exciting, and the research is beginning to come out now, shows that it does actually work on a number of different levels. There are psychological therapies that have been proven to help. Again, I'm talking generally now, but a part of the coming off the medication is, apart from the difficulties we've talked about and you just eloquently summarized, if you're going to come off the medication, you need something else. Because medication was doing something, like only calming you down. But there are treatments that work. They're not always as available as we would like them. But for instance, cognitive behavior therapy for psychosis, a particular type of, as an evolved form of CBT, developed here in Manchester and England for psychosis, is proved to be very, very effective. And that's not about getting rid of the symptoms, or it's more about learning to live with them, dealing with the stress and improving quality of life, using cognitive therapy techniques to help you understand the voices. Because if voices don't go away, they can be understood. Some of the problem is that I know we've got away from medication, we can come back to it if you like, but I think it's important for people to realize there are alternative treatments, because part of why people got stuck on the medication so long is that there isn't anything else. That's all there is. And that's just not, well, it might be true for an individual biological psychiatrist. You might not have the skills to do therapy or even know about the Hearing Voices Network. Some of them are very sort of head in the sand, sort of blinkers on about these things. So there are alternatives, and CBT for psychosis is quite a wonderful approach to helping people understand their voices and delusions and learn to not be freaked out by them, which is a wonderful thing to do, I think. So yeah, there are ways through it, and I think what you mentioned about the Facebook groups, unfortunately, at the minute, and you'll know this is true about antidepressants. I'm chair of the International Institute for Psychiatric Drug Withdrawal, and you are on that board, so you'll know this stuff very well. So tens of thousands of people trying to get off antidepressants are currently getting most of their support from Facebook groups in the absence of professional support. So that there are support networks out there, like the Invoices Network, like the Facebook groups that are out there, and you can get good advice. Of course, you can get bad advice as well, but you can get bad advice from a doctor. But you can get support and empathy, and people going through the same sort of thing. So there is a way through, and I think in time we're certainly making progress on antidepressants. Certainly in Britain and Europe. I think that's slower to come in the States. We're very close now to getting specific services off the ground in Britain to help people get off antidepressants. I think antipsychotics will take longer because of all these fears we've talked about. But in time, we will recognize the need for specific types of services to help people come off these drugs without going crazy, or if they do, to help them through that temporary craziness, if we can use that word.
Yeah, because I mean, there's not even... I don't know of any places in the US where it's like an inpatient unit where someone could go for an episode of psychosis if they are behaving in a disinhibited way or a way that's scary for other people, where they could just go and sit there for a couple of weeks and be monitored and have some Ativan occasionally if they needed to sleep, and they kind of just leave them alone. That type of service doesn't exist.
The Schizophrenia house in the 1970s and 80s was very well researched and was as effective as treatment as usual in hospitals with medication. Schizophrenia house is just treating people in normal houses with staff who weren't necessarily mental health professionals. Their main quality was what I like to call unfreak out ability, their capacity to just sit with someone in an altered state and not do anything other than be there and take care of them and be supportive for that person. And that worked as well at a symptom level as drugs at hospital, and better at a social level in terms of getting back to jobs and friends and so forth. But that was squashed almost because it worked so well, which is a bit of a cynical thing to say, but it's true. And there are some places like that around the world. Norway at the moment has a government-sponsored program of having a certain number of beds in each psychiatric hospital which have to be drug-free, which is pretty exciting. It's getting a lot of, as you can imagine, a lot of pushback from biological psychiatry trying to sabotage it, but it's hanging in there. It's not that they're drug-free, it's that they have in those beds, the person has to have the choice. And if they want to be drug-free, then no one can make them have the drugs. That's the difference. And the other bit we haven't spoken about in all of this is the coercion involved, because it's very hard for someone to feel that they're in a therapeutic relationship with a professional who can make them have a drug and can make them be held down on the floor and have that drug injected into them if necessary in a hospital. There's a lot of people aren't aware that you can forcibly inject a drug so that that person has no choice for the next 3 months. It's in their system and that's it. And that level of coercion, I believe, is a human rights issue. And there are no other branch of medicine or no other types of illness, even cancer, where we know that certain treatments can actually save lives, where you can make somebody have the treatment when they say they don't want it. But this group of people is legally a second-class group of people who you can do that to legally. Even though we know the drugs shorten lifespan, reduce brain volume, do all these other things, you can forcibly make somebody have it. And I believe that's a human rights issue.
I'm just going to spell that out just with an example of what that looks like. So we're talking about an outpatient medication commitment. I mean, in psychiatric hospitals, you can get inpatient commitments, but if someone is repeatedly coming into the psychiatric hospital, a psychiatrist may petition a judge, this happens in the US all the time, to do an outpatient medication commitment, and then ACT teams, these assertive community outreach teams, usually there's a social worker and a psychiatrist, will periodically go to the person's house, maybe once a month, with their depot medication, with their 1 month long-acting antipsychotic injectable, where they get an injection and it forms a drug clot in their arm, which slowly dissolves over a month or 3 months or sometimes 6 months now, some of them, and give them the medication. And so they go in there and they say, you've got this commitment, and the person essentially has to comply. And on the occasions when the person simply doesn't open the door or isn't there, the psychiatrist can, in their discretion, call the police to pick them up and bring them to the psychiatric hospital and use their absence of being there and opening the door as signs that they have a grave psychotic illness, that they're grossly psychotic because they're not complying with this treatment, which is in their best interest. So you have thousands of people across the US who are in this situation now where they're simply just having to comply with this, these medication commitments, which are granted by judges, community judges. Yeah.
And if that isn't a human rights issue, I don't know what is. There's good, we call them community treatment orders here, same thing. There's only ever been 2 randomized controlled trials of community treatment orders, and they don't work. They do not reduce, the rationalization for them is that this is a humane, liberal approach because we can let people out of hospital. We can treat them in the community, and we're doing it for their own good, so they don't have to be in hospital. So we can reduce the hospitalizations by using these community treatment orders. But it doesn't. There's no evidence that it reduces the amount of hospitalization. And this is a rather strong statement, but I'll make it anyway. I don't believe we are operating in an evidence-based system. So the fact that it doesn't work doesn't matter. I don't think psychiatry as a whole, and this is a huge generalization, I think psychiatry is quite different from other branches of medicine in as much as it is not most of the time evidence-based. So it doesn't matter that doesn't work. It doesn't matter that the research says that antipsychotics are no better than placebo, other than perhaps the first 3 or 4 weeks. After that, there's no difference between placebo and antipsychotics. It doesn't matter that they reduce lifespan and they cause diabetes in such great numbers, etc., etc. We're not living in an evidence-based world here. And I know that sounds like an extreme statement, but I believe the evidence for that statement is overwhelming.
Why doesn't it, from your perspective, why doesn't it matter to the psychiatrists and the psychiatric leadership to practice in an evidence-based way?
They believe they are acting in an evidence-based way, obviously. That's a huge question. I think some of the time, this gets me in trouble as well, some of the time they just don't know the research. They just believe they have so many visits from drug company representatives who tell them this drug works, this drug is safe. Education, I don't know if is it still the same in America that most postgraduate education is run by drug companies? Has that changed?
Yeah. I mean, if we're talking about reading journal articles and going to conferences, the majority of them are generated by drug companies, whether it's the speakers or the articles. Yeah. So
it is evidence-based, but it's based on the evidence that the drug companies choose to present to psychiatrists.
It's marketing.
I think it's a bit naive, really. The major, people ask me, how did we get into this mess? And that this is simplistic, it's more complicated than this, because we all go along with, to some extent, with a medicalized view of, we all accept the pills the doctor gives us, but usually we'd like to trust doctors, which is a nice thing to be able to do. But if there's one point in history or one fact that got us into this dreadful mess that we're in. It's when the profession of psychiatry abandoned a proper boundary between itself, a medical profession, and a profit-oriented industry. That boundary crumbled. I think to argue about when it was, I would put it around late 70s, early 80s. And we really have drug companies largely running psychiatry. I mean, the American Psychiatric Association is hugely funded by drug companies. The DSM is effectively written by psychiatrists in the pay of drug companies. And in my field of schizophrenia, every single member of the DSM-5 psychosis committee was being paid by drug companies one way or the other. Research money very often comes from drug companies. You go on the internet and look something up. We've done studies showing that more than half of internet sites on psychosis or depression or anything, are drug company websites. It's not just America. In the National Health Service, we did a study 3 or 4 years ago, looking at how often training of our mental health professionals was done by drug companies. It's off the scale. So yeah, it's evidence-based, but it's the evidence that drug companies choose to give to psychiatrists. And somewhere along the line, they've lost sight of that. It's very sad. In 2005, both heads of psychiatric associations in Britain and America, head of the APA and head of our Royal College of Psychiatrists, publicly condemned the extent to which the profession had become subjugated to the drug companies. Our guy, I'm very proud of him, Michael Shafter. He wrote about, I can remember the quote exactly, and I use it a lot in my lectures to explain it, and to get across this. Not all psychiatrists are naive. He said, I am ashamed by the number of psychiatrists at the airport with so many drug company gifts in their luggage. They might as well have the name of the company tattooed across their foreheads. That was the head of the Royal College of Psychiatry in 2005. Sorry, I get it. It makes me upset because these are not stupid people, psychiatrists. They're well-meaning people. They want to help. They think they're helping. And no doubt sometimes they are helping, of course. But overall, the model they've been filled with is nonsense. It's unhelpful. It's damaging. And it gets in the way of their innate goodness, their innate wanting to help, makes it almost impossible for them to do so, which I think is very sad for them. That's why I get upset. Sorry.
What's going on? Why are they blind to what has happened to the profession? Why can't they see what's going on? That's hard to say. I mean, some of them don't think anything's. I mean, they think, well, John, yes, the drug company's there, but I'm not naive. Of course, I take it with a pinch of salt if it's a drug company. Piece of information. My favorite bit of research on that is it's an Australian study it's way out of date now, probably 30 years ago, but somebody did this great study with Australian psychiatrists, asked them 3 questions. Number 1, have you received any money from drug companies in the last year? Number 2, were you influenced by that? Number 3, were any of your colleagues influenced by that? The answer to the first question was 90% had received some sort of funding from drug companies. How many were influenced by that? 10%. How many of their colleagues were influenced by that? 70%. It's like, are you better than the average driver? I'm fine, everybody else is great. So they could see it, but just not me. It's cognitive dissonance again. It's, of course I know drug companies, but some of my colleagues, they just stay overprescribed. But the advertising and the planned advertising and marketing of the drugs and the model that goes with the drugs is very efficient and skilled. The drug companies don't spend a penny that isn't effective. Their research is better than ours. They know how to get good outcomes for themselves. So it all sounds really paranoid, doesn't it? Well, I think I think these things are good to talk about. I love talking to people about their perspectives on how we've gone astray. And, it's useful because I feel like people, and this is especially the boomers that I treat, they look at doctors in a different way. There's this respect and aura about them. These are objective people. They have my best interests in mind.
We all want
and
to
I feel
believe
like
that.
there's less and less on that. Yeah. And even some of the younger people, but they're a bit more skeptical now because I think there's been maybe a bit more cynicism about institutions as kind of different things have happened over the years. But I liked what you said about money exchanging between doctors and drug companies, because what people usually don't talk about is the pervasive influence of relationships. And they just go, the doctors are objective all the time. But I mean, there's very strong evidence from marketing that if you give people gifts, that they can, you feel like you need to reciprocate it. You feel indebted to them in some way. So there's all these marketing techniques out there where drug companies will, work to create great relationships with doctors because there's clearly a financial incentive there. They'll give them things. They'll, put on lunches. Oh, we'll give you some sandwiches. Don't worry, you're never going to be influenced by that. But it's just the psychology there where you're just saying, this person's okay.
Isn't that a beautiful or horrible irony that the drug companies understand the importance of relationships better than we do? What I mean by that, I'm going to give you 2 examples to explain what I mean by that. I was talking before about CBT for psychosis and how it works. Having established that it works, they went on to try and find out how it works and why it works. They put in all the variables, experience of the clinician, how well they stuck to the manual, how severely disturbed the patient, blah, 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 blah. And they put in therapeutic relationship. And the most powerful predictor of a good outcome was, surprise, surprise, the therapeutic relationship. Even more interesting was in our survey of people on antipsychotics, we asked them about their relationship with the person who had prescribed the drugs. Did they think they had been listened to? They were all on the drugs. They'd all ended up on. Had they been listened to, et cetera, et cetera? Did they please rate your relationship with the prescriber? And their perceived relationship with the prescriber massively predicted how well the drugs worked. That's how important the relationships are. And how can we miss that? What people need, whether we use medications or CBT or what open dialogue or whatever it is, people, if we understand the basic, and this is, I guess, if I have one message, it's this. If we understand the basic truth that most of the time when we're upset, it's because bad things have happened to us, usually in relation to other people, one way or another. Mm-hmm. Not all abuse, but something has happened, gone wrong in our relationships with other people. So what's going to fix that? Surprise, surprise. A good relationship with a human being who's going to sit and listen to us. That's it in a nutshell. We can go around the house. And our mental health system, most of the time, is not able to provide that. That's the problem.
Yeah, well, there's 2 things. There's, we don't get enough time to spend with people because of the payers.
Yes.
But it's also in the training as well. Yes. There's kind of skeletons from Freud of the impartial psychiatrist who's not, you don't share too much, you keep your distance from them emotionally. And some people, they just want to keep their distance because it's an awful hard job doing that. And so that's a very normal reaction. And if you have 15 minutes with someone, let's keep it clinical. Let's not go into too much pain. I don't want you walking out of here crying. That's going to be very disruptive.
I'm going to jump in. I'm going to be rude and jump in. If you're the sort of person who is easily upset by other people's upset, get out of the business. I think you're absolutely right to point that out. These people are people, and it's painful to listen to other people talk about what's happened. It's hard work and it's painful and it's not for everybody. Go do something else. Sorry. That's
No, that's it.
Why put yourself through that for the next 30 years? At the same time, damage all these people you're so scared of, their feelings and their pain. Go. I'm sure there's something else you're good at. You're probably a good musician or something. Go do that.
And well, that's the thing. I think the people who are most afraid of uncomfortable emotions will probably be the ones that will reach for the pad more, because that's frightening. And so, another thing, just touching on relationships. I know you're mainly clinically focused, but I know you know this about me. I worked at the FDA and several pharmaceutical companies, and so we were talking about the importance of relationships. So I think it's always interesting to bring up the issue of why does it take so long for drug regulators to recognize serious adverse reactions to drugs, whether it was the suicide risk with the antidepressants or PSSD, protracted withdrawal, all of these different things. And I think about my time at the FDA and my time in industry and being at the conferences and what I saw, and it's probably not a surprise that many people know that FDA is one of the best ways to get a job in pharma. In fact, I did that, and I tripled my salary when I went from FDA to industry. But so you've got a situation where you have got a former FDA officer in a pharmaceutical company running a clinical trial who is then submitting protocols for drug approval or submitting some paperwork saying that, this problem isn't really an adverse reaction. It's not, there's not enough evidence. They're submitting it to the people that they used to work with. FDA is a really tight-knit community. Usually everyone's kind of getting together at these gatherings. Sometimes these people are people who've held your hand when a spouse has died or when something terrible has happened to your kid. These are people who have sent you, when you were in the FDA, they've sent you Christmas cards. They've been with you, when maybe you went through cancer or something like that. These are incredibly deep reciprocal relationships where they feel bonded, and then they go to the other side and they still have all that goodwill. They're, Josef or, whoever's over on the other side in the industry, they're a great person. They were there with me when I needed them. They would never do something like this. And so they've got there's this indebtedness there from the relationship. And I think that's incredibly powerful.
Yeah.
Yeah.
Interesting.
Yeah.
Good.
The other thing that was,
sorry,
yeah. Well, the one last thing I was going to say, there was a lot of interaction between drug regulators and industry at conferences. And again, it's a serious problem where you have the drug regulators spending more time with industry than with actual patients. There was one time when I was at the FDA when FDA people spoke to someone who had an adverse reaction, and it was at my urging that we did so. And they acted like it was the craziest thing that had ever happened. And so you've got mainly drug regulators just kind of going to conferences with industry a couple times a year, forming these relationships. And then we wonder why the side effect detection apparatus is so broken in the US, but it's relationships. These are the subtle forces at play that have that pharma understands that the doctors don't seem to see. Yeah, it's nuts.
Paradox, isn't it? Yeah.
John, please go ahead and tell us about this important research that you're conducting.
Okay, so electroconvulsive therapy, or I think in the States it tends to be called electroshock therapy, is probably the most controversial treatment in psychiatry. And the reality is we really genuinely don't know whether it works. So we've designed some research that might help us answer that. When I say we don't know, what I mean by that is that there has not been a randomized controlled placebo trial, the gold standard for establishing whether something works, since 1985. So what's that? 40 years. Before that, there were 10 very small, quite flawed by modern standards studies. 4 showed there was a difference between placebo and ECT. 5 showed there wasn't a difference, and 1 psychiatrist saw a difference and the patients didn't. Then placebo just very quickly, in this case, is you give someone the general anesthetic, but you withhold the electric shock and the convulsions. So there's a lot of claims that it works, and there's a lot of claims that it doesn't work. And the reality is we just don't know. Now, we have been trying to encourage them to do a proper randomized controlled trial for a long time. They say that would be unethical because we can't withhold a treatment that we know works, which is a very odd position. It kind of puts them outside of science altogether, because that's the whole point of doing a randomized controlled trial. But that's another story. What we're doing, we've got an online international survey for people who have had ECT and their relatives or friends, asking them a whole range of questions about whether it worked for them, if it did work, how did it work, what were regardless of whether it worked, what were the side effects? Because another area of controversy around electroconvulsive therapy is how much memory loss it causes. Some people say it causes a lot of memory loss, which is permanent. Psychiatrists who use it say, it's quite rare and it doesn't last more than a few weeks. So, and again, the research is a bit blurry on that. So again, we thought we would just ask people what they think about that, people who've had it, and people who are mums or sisters or whatever, sons or whatever. We're also asking them what they were told about ECT before they had it. We were asking in the survey, what do they think caused the problems for which they were given the ECT? Do they think it's biological? Do they think it's psychosocial? If they think it's psychosocial, what do they think about? All of those sorts of questions. And we're literally just trying to get as many people as possible to complete this survey. It's not perfect because it's not a randomized sample, but it's going to be 10 times bigger than any other survey ever done, or any other ECT study ever done by the time we're finished. So it'll be valuable in that light. We want people, at the minute we've got 350 respondents. They're mostly from the USA and the UK, which is fine, but I think we've only got about 14 other countries with small numbers. When we've done our big surveys of other antidepressants and antipsychotics, we've usually ended up with 35 or 40 countries contributing. So we're trying to get it out there and encouraging people to take it themselves if they've had ECT or know something, but also to disseminate it, to pass it on to their networks, their mental health networks.
Okay. And so the link to that survey is going to be on the side of this video. And so if that's you, we would love you to fill it out.
Thank you, Josef.